Dr. Luma, I changed your name, so it has JAYSO.
Thank you. Thank you so much.
You're welcome.
All right, are we ready to get started? Can you guys hear me?
I can hear you, yes.
Yes.
Okay, cool. Good morning, everyone. Welcome to our first grand rounds of the academic year. Unfortunately, Dr. Hartley couldn't be here today, so I will be introducing our speaker today. We have Dr. Jason Luma, who is the section chief of the Pediatric Emergency Department at Valleywise Health Medical Center in Phoenix, where he has served since 2023. He has over 2 decades of experience in the Valley's high-volume emergency departments, including Banner Desert Medical Center. Dr. Luma is known for his clinical acumen, empathetic bedside manner, and commitment to evidence-based humanistic patient care. So welcome, Dr. Luma.
Thank you, Dr. Parker. So as Dr. Parker graciously said, my name is Jason Luma. I'm section chief of the Pediatric Emergency Department at Valleywise Health Medical Center. And I'm extremely grateful for the opportunity to speak at this morning's grand rounds. I'd like to share a little bit about myself to lend some context to the talk. I trained in pediatric emergency medicine in the Northeast over 2 decades ago. I've spent nearly the last 2 decades here in the Valley, initially working at Banner Desert Medical Center, which is one of the highest volume combined emergency departments in the country, and now since 2023 at Valleywise Health Medical Center. First and foremost, I'm a clinician first. And that's where these principles I'm about to talk about actually come from. They're not rooted in textbooks, but rather from the bedside, from mistakes and from listening to my patients and families throughout my career. Today, I will be speaking about Luma-isms, principles I've named after myself clearly, hard stops, cognitive biases, and the clinical art of humanistic medicine through a case-based review. First, these Luma-isms are not entirely my own creation. I've learned them from many different experienced providers throughout my career, colleagues, mentors, sage pediatric emergency medicine providers who I've been fortunate enough to work with and learn from over the last 2 decades. I have, however, taken them, refined them, and made them my own through daily practice. Luma-isms, in short, are simplified clinical hard stops learned throughout years of bedside experience that trigger awareness when deviation from proven practice patterns occur, anchoring decision-making amid the stress of pediatric emergency care. While I probably have over 50 Luma-isms, These are some distilled from my own life's work in the pediatric ED, which I've incorporated into my practice. I'll be diving deeper into some of them by way of the case-based reviews, but I wanted to list a few of them that I use most and show you my toolkit here first. These Luma-isms, to me, represent hard stops that have helped me save lives, catch diagnoses, and have kept me centered and present when the world around me feels chaotic. The first Luma-ism, and one of the most important ones, is vital signs are vital for a reason. As clinicians, we trust objective data even when the clinical picture seems benign. For example, a child with persistent tachycardia, regardless of the source, should not be ignored. For example, a child comes into the emergency department. He has clinical strep pharyngitis, a positive PCR, but after fever control, he still has persistent tachycardia. When you dig deeper, you find that he has a round pneumonia and potential for strep bacteremia. Number two, a walking child should always walk. A walking child who will not walk or move typically has pathology until proven otherwise, not malingering or behavioral issues. For example, a child who has a minor injury falls but won't bear weight despite negative x-rays and pain control has an occult fracture or growth plate injury until proven otherwise. Immobilize the child. 3, the stupidest kidney is smarter than the smartest doctor. As providers, we must respect physiology. The body's signals outsmart our bedside assumptions. For example, a child who appears well hydrated and active but has a reliable history of oliguria and or anuria should be worked up further and evaluated more deeply. Number 4, and the only question framed as a Luma-ism, who is the best provider you know? Of course, this is a rhetorical question. We trust in our clinical instincts and then verify. We don't blindly refer to what's already been documented. For example, parents that report from an outlying ED with reports of a negative urine analysis or a blood culture or a strep screen, we trust but verify. We repeat tests if clinically indicated, but not blindly defer to prior results reported. Number 5, never send a vomiting child home. Persistent vomiting signals pathology until ruled out. Don't discharge based on reassuring labs alone. For example, a child with persistent vomiting could have significant pathology, such as CNS pathology, foreign body ingestion, non-accidental trauma, or other serious etiologies. These are a few of my hard stops that I put into daily practice. Now let me show you what happens when you honor them and when you don't. It's 1 a.m. at Tucson Medical Center. I'm in the doc box surrounded by a sea of ear infections, screaming children, respiratory illnesses, and acutely ill kids. I'm pretty much just trying to stay afloat, waiting for the next sick kid to come through the doors. I'm moving quickly, dispositioning and trying to manage amidst the chaos. I'm already frustrated because they keep piling up. The pressure is mounting. As I turn to my left, nursing is leaning on the frame in the doorway. She reports there's a 12-year-old female in room 1 who fell in the shower and, quote, now she's having an anxiety attack. Can you please go and see her, Dr. Luma? I cannot get her to calm down. Nursing appears frustrated. As I get up and walk to the room, it's at this point, at this very moment, that the anchoring starts. The framing is already primed. I'm walking into the room expecting anxiety even before I lay my eyes on this child. As I enter the room at the far end of the hallway, it's poorly lit. The mother is sitting at the foot of the bed, stroking her daughter's leg, who is hysterical and hyperventilating. The mother is enabling her behavior, I think to myself. The mother reports she failed a math test and fell in the shower. The child blurts out that she didn't take anything. The mother does confirm after a brief history that the child has no history of suicide attempts, ingestions, nor gestures. The child has no past medical history, behavioral history, or psychiatric involvement. I glance up at the monitor at the far end of the room. I note sinus tachycardia. I look back at the child who continues screaming and yelling. I attempt to verbally de-escalate the child, but I am unable to do so, and therefore, to some degree, I think frustrated. I do note mild mydriasis on physical exam. However, I rationalize this given the high sensory overload, poorly lit room, and extreme anxiety felt. As I exit the room into the main nursing area, it's brighter, but still busy, still chaotic, and definitely active. I turn to nursing. I've anchored on anxiety at this point. I order a toxicology workup, including an EKG as per protocol for behavioral clearance, but then I get scooped up into the busyness of the ED, the noise, the chaos, and the next question from nursing that's coming. I'm already moving on mentally. The next bed, the next patient, the next problem. I order the labs, the EKG, and move about my shift. I'm sitting in the doc box. About 30 minutes past, and nursing again presents at the doorway. We need to give her something, Luma. She's inconsolable, and I cannot even get vitals. She hands me the EKG scene, and I review it briefly. I take quick note of the T on P wave phenomena, but I'm anchored on anxiety, so I gloss over it. Tachycardia, stress, mydriasis, and the general feel of that room fit the narrative I'd created in my head of anxiety. That's anchoring bias at work. I had the clues, but dismissed them. I dismissed the objective data right in front of me. So I ordered benzodiazepines, Benadryl, and moved on to the next patient. A short time later, her labs returned. She had a normal aspirin level of less than 4, a non-detectable acetaminophen level, and a negative urine drug screen. In fact, all of her labs were quite reassuring. I subsequently cleared her for psychiatric evaluation, formally. I treated the labs, not the patient. That's another Luma-ism. She was sedated, yet not improving. I had premature closure. I'd anchored on anxiety and could not see the forest for the trees. I had already mentally closed this case. Excuse me. No subjective data contradicted my decision to clear her for psychiatric evaluation. The story remained the same. Same failed math test, same fall in the shower. But objectively, the findings were piling up. Mydriasis, tachycardia, bizarre behavior, now fever developing. She sedated, but worsening, I thought, not improving. I'd already decided that this was anxiety, but the clinical picture was pointing to something different. My anchoring had blinded me to what was right in front of me. Shortly thereafter, the sitter approaches me. Dr. Luma, her respiratory pattern is off. She's becoming somnolent and then begins to breathe hard again. That one comment, that moment, that's all it took to crack my anchoring. That sitter's astute observation amidst the chaos pulls me back. And I do what I should have done an hour ago. I look at and examine the trends of her vital signs. For 60 seconds, I reviewed what had been there the entire time. My Luma-ism, as I recalled, centered me during the chaos. I thought, vital signs are vital for a reason. Persistent tachycardia throughout her entire ED course, not responsive to anxiolytics. Subsequent to this, I ordered an ISTAT venous blood gas, which showed respiratory alkalosis. I noted that she had continued mydriasis, continued bizarre behavior, now respiratory abnormalities. The pieces of the puzzle at that time began to fall into place within my mind. Fever, persistent tachycardia, respiratory alkalosis, mydriasis, and altered mental status, along with bizarre behavior along that continuum. This was not anxiety. This was not a behavioral presentation per se. This was a toxic ingestion. At that moment, I knew. I consulted toxicology, and her repeat ASA level was greater than 200, dialyzable. The child had taken an entire bottle of enteric-coated 81 milligram baby aspirin, which was found later that evening under her bed. The enteric coating caused delayed absorption, allowing for the pills to clump together in her stomach and form a bezoar. That's why the initial ASA level was normal. She had delayed absorption, owed to the bezoar. The child was admitted to the ICU, treated appropriately, and made a full recovery, all because I honored one hard stop. Vital signs are vital for a reason. And that's the lesson. I anchored on anxiety, which led to premature closure. Normal labs reinforced that closure, but the hard stop pulled me back. The hard stop is what saves lives. A different presentation, two different Luma-isms, but the same stakes. Listening matters. The first case teaches that when it's difficult to see the forest for the trees, vital signs tell the true story and do not lie. The next case melds two different Luma-isms. A walking child should always walk, and who is the best provider you know? This case teaches something equally important: the power of listening, teamwork, and trusting your gut when the clinical picture doesn't add up. Day 1, 14-month-old male presents with fever, tachycardia, and a chief complaint of not moving the right leg normally. He was evaluated appropriately. The exam documented full range of motion and normal leg movement. He was subsequently discharged home with a diagnosis of viral illness. But here's the thing: a walking child should always walk. When a child presents with a concern about leg movement or pain in an extremity, that is the hard stop. That's the trigger that should prompt us to dig deeper. Day 2, he's back. He's still febrile, ill-appearing, with abdominal fullness and subtle tenderness on exam, clearly changing from his previous 24 hours. He's tachycardic out of proportion to the degree of his fever. He was seen and cleared 24 hours prior to this current presentation, I recall, but I don't accept that clearance blindly. Notably, there's no documented ED leg complaint from the previous visit in my review. I work him up. This is where the two Luma-isms converge. Who's the best provider you know? We trust our gut instincts. We trust but verify. And a walking child should always walk. Those two rules triggered me to dig deeper. After some time passed, his labs returned showing significant inflammation. His white count was 18,000 with the left shift. His CRP was 320, and his procalcitonin was 9. I ordered an ultrasound thinking potential for presentation of atypical appendicitis with possible rupture, looking for the source of his belly pain and overall clinical presentation. Ultrasound failed to visualize the appendix, and therefore we proceeded to obtain an CT of the abdomen and pelvis with IV contrast. That's when we as a team caught it. A right hip fluid collection, psoas muscle phlegmon, and resultant pyomyositis. Sometimes a blind squirrel finds a nut. I ordered imaging thinking appendicitis, but caught the septic hip. That's luck, but luck is not a strategy. But the real hard stops: a walking child should always walk, and who's the best provider you know? Those are the rules which drove this diagnosis on day 2. You don't accept prior clearance. You trust yourself and you verify. This is what happens when you honor the hard stop of a walking child should always walk. You will catch underlying pathology that otherwise may have been missed. And while this child did not have appendicitis, he had a septic hip, psoas muscle abscess, pyomyositis, with resultant strep pyogenes bacteremia. But it could have easily been something different: a fracture, an oncologic process, non-accidental trauma, or any other serious pathology, including appendicitis, but not limited to. The point is, a child who won't walk has pathology until proven otherwise. It's our job to find it. Our job is to prove that the child is well, not their job to prove that they're sick. That is the burden of proof that we are tasked with as providers. Using these Luma-isms creates a pattern of behavior. Every time you see a child that won't walk, that hard stop fires. It makes you pause and think. It makes you document. It makes you expand your MDM and differential diagnosis and dig deeper. Over years of practice, they've become muscle memory, automatic clinical instinct coupled with awareness, visual cues, and listening. These two cases illustrate different lessons, but the same principles. Case 1 shows anchoring bias and premature closure. Vital signs are vital for a reason, is what stopped me, what broke the cycle of my anchoring. Case 2 demonstrates pattern recognition and teaches the burden of proof. A walking child should always walk, and who's the best provider you know. Both teach to trust your clinical judgment, verify, and listen. That is the humanistic art of clinical practice. In closing, these Luma-isms are principles that have guided and shaped my practice for decades. They're not complicated. In fact, they're quite simple. They take complex cases and give you a clearer view of what really matters. They bring you presence. They center you when everything around feels chaotic. They've caught what others may have missed. They've pulled me back from bias and misdiagnoses, and they'll do the same for you if you hone them and use them. That is how you practice medicine with integrity and humility. I want to take a little bit of time to talk about documentation because it matters. All the residents I work with know I harp on documentation. I say document defensively, but don't practice defensively. That's another Luma-ism. On day 1 in the second case, if that hard stop had been honored, a walking child should always walk, I would have stood the child up, assessed gait formally, and documented any abnormal or normal findings explicitly in the medical record. When you document defensively, your exam becomes more robust and guided. Your MDM becomes more enlightened because you consider a broader differential. The same principle applies to the hard stops. When you consider the hard stops, you consider other differential diagnoses besides and broaden your evaluation. When you document defensively, you document what you see and also what you don't see. For example, a child who presents with fever, croup-like symptoms, and while you're evaluating or assessing for retropharyngeal involvement, you don't simply document normal neck exam. You explicitly and specifically write that the child demonstrates full range of motion of the neck without restriction with lateral neck movement, nor evidence of retropharyngeal involvement, because that is your next best diagnosis. That specificity matters. That specificity, for me, carries through multiple areas of the chart. For example, the last line of my history in that situation would state, as I enter the room, the child is being held by the father chest to chest. He turns over his left shoulder and makes excellent eye contact with me. I'm saying that he does not have restriction with lateral neck movement without specifically documenting it there. And that will also be specifically cited in the MDM and help build a more robust MDM when you're considering differential diagnoses. Here's what I want you to understand about these hard stops. They're not magic. They won't catch everything, but what they will do is change how you show up. They will make you pause amidst the chaos. They will make you listen instead of rush. We are not infallible. We are human. And I've shown you 2 cases where I've made mistakes. I've anchored where I've had premature closure, where I didn't listen as deeply as I should have. But the hard stop, these Luma-isms caught me. They brought me back. That's not about perfection. That's about practicing with integrity, admitting where you went wrong, learning from it, and doing better. And that is the conversation I'd like to have with you today. Thank you so much, and I'm happy to take any questions.
Thank you, Dr. Luma. I'm going to
Thank
turn
you.
the ceiling mics on so the audience can ask any questions. And then we have lots of people over Zoom, so I am looking at the Zoom chat to see if anyone has any questions over Zoom.
Sure. I think it's an unorthodox talk. You know, it talks about more humanistic aspects of the clinical exam, centering yourself amidst chaos. So I think it's
Do you have
really
any tools for residents as they're kind of like starting their training to incorporate hard stops, how to pick up on their biases when they're still in training and feeling maybe some imposter syndrome?
That's a very good question. You know, I really reiterate these hard stops and talk about the bias that they can actually even create in some occasions with the residents from day one. These tools don't take the place of decades worth of experience, but the way that I see physicians developing is by being surrounded by quality physicians that they take pieces from each physician that they like. And so I do teach to these hard stops, but these hard stops by in no way are clear hard stops in the sense that every child that meets this criteria has to have this excessive workup or admission or always has some sort of underlying pathology. But what they should do is generate a pause within the provider to consider, you know, or rationalize why they might be doing something differently. And in certain instances, it's fine. But I teach to the hard stops, and I think it gives the residents a tool to a visual cue to really kind of trust their gut instinct and realize when something's wrong. Everything in life is a language, and so much of medicine in general can be an apprenticeship. So if you follow people around over enough time, you could do what anybody does. You could speak that language. And I think one of the biggest ways to do that for me in teaching is to relay these hard stops to the residents and to my colleagues. They hear me say them all the time. And I'm sure there's a lot of residents in the rooms who've worked with me before. Dr. Parker, you have as well. And I'm sure I've said these Luma-isms to you, which I actually coined for this grand rounds. I've never called them that.
You can post them around the ED now.
Yeah. Yeah. I think one of the questions, you know, because I know that sometimes it's hard to talk. I mean, and you can interrupt me if you want, it's fine. But I think one of the questions I get is, how do you avoid the false positives, you know, working children up? How do you rationalize the cost, potentially the trauma associated with IV placement, admission, the bills? You know, I think that some of these these hard stops are made to create or to not miss illnesses with potential catastrophic consequences. So for me, those false positives, as long as you're upfront with the family, you have the child's best interest at heart, and you share decision making in your plan and judgment, and you have empathy. You know, I would take those false positives against missing septic hips, you know, significant pathology. And these hard stops are a ceiling, not a floor. You know, like I follow, you know, protocol-driven pathways, sepsis pathways, but that's the floor. The ceiling is these hard stops over that.
All right, and then we have a couple of comments from the chat. So somebody said, not a question, but just to say many, many thanks to Dr. Luma for his excellent insight. Somebody said, similarly, my gut feeling has steered me well as long as I listen to it. And then lastly, somebody asked, do legal problems play a role in Luma-isms?
That's a great question, and thank you for the other comments. I have never really had an issue with respect to legal issues, knock on wood, specifically with respect to Luma-isms. I think defensive documentation and these hard stops and rules that I do are legally protective in many instances. And to some degree, some of them are created in that prism, in that framework. I think it can trip you up in the setting of you have a family, you work up, there's nothing comes of it. You know, maybe the kid has transient synovitis and not a septic hip, or whatever the diagnosis may be. They're upset, they have bills, they have anxiety and trauma. So I think that it could present in that way, but I think so much of avoiding medical legal pitfalls in medicine is your bedside demeanor, how you come across, admitting your mistakes and your faults, sitting down in the room, having excellent eye contact, and always demonstrating that you have the best interest of the child at heart. And I think that really goes a long way to avoiding any downstream issues with respect to medical legal ramifications.
All right, any lingering questions or comments from the audience? Okay, well, thank you, Dr. Luma. We really appreciate it. That was a great talk.
Thank you. Thank you. I hope it was enjoyable, and I really appreciate you offering the opportunity to speak at Grand Rounds. It was a real honor. Thank you.
Thank you, Dr. Luma. Have a great day. Thanks, Dr. Parker.
Thank you, Dr. Parker. Thank you, Ozzy. Thanks, everybody.
Bye.